Yeah.
Third year is IPR in Sedang.
Okay. It's good lah. All right. All right. Anyway, I'll see which of this I can even remember. I just drove
But
in.
anyway, it's very, very brief, like the woman. I think so complicated.
Okay. Anyway, so anyway, I'm sure I'm going to enjoy your talk.
So just a simple talk on the Toma, just some prepared slides, previous old slides kind of thing. Didn't have time to make new ones.
No
I
worries
just
lah.
modified a few slides.
Okay, so I think it's 2 o'clock already. So I will, yeah. So 3 o'clock, yeah, sorry.
Yep. I think Afiq, can we start?
Yes, we can start now.
Right. Okay.
Dr. Paras is here. Hi, Dr. Sri, do you want to give anything, Dato'? You have anything to talk, Dato'?
Hi, Paras, can you hear us?
I think his internet quite problem.
In Perlis.
Yeah, in Perlis.
Okay.
Lost him already.
So, do you want to
we just start first? Okay. Hi, everyone. Good afternoon. I'm Dr. Liu. I'm a physician from Hospital Taiping, and we are currently having the weekly webinar organized by the College of Physicians of Malaysia. And currently, we are in the month of respiratory, February. And today we have a speaker today, Dr. Sangeeta. We will be presenting on the topic vaccines for chronic respiratory illness. And the chairperson today will be Dr. Uma Devi. Just a brief introduction for Dr. Uma Devi. Dr. Uma graduated with MBBS from University Malaya in 1994 and further obtained a master's in internal medicine from USM in 2002. At the same time, also she obtained the MRCP from UK in 2002. She completed her fellowship in Respi in 2007 and subsequently served as a respiratory physician in Hospital Taiping before moving on to her current post, which is a respiratory physician in Hospital Pulau Pinang. Without further ado, I will pass over to Dr. Uma.
Okay. Thank you very much for the kind introduction, Dr. Liu. Actually, you're from a place very close to my heart because I was working in Taiping for many, many years. I even did my gazettement there as a physician. Subsequently, now I'm in Penang, which is also a very nice place to work. Very idyllic. So without further ado, I would like to introduce Dr. Sangeeta. I'm very lucky to have Dr. Sangeeta today. She's a very bright and brilliant speaker. I had the privilege to work with Dr. Sangeeta when she was doing her training and when she completed her training as well. And she was in Penang for a while. So Dr. Sangeeta actually graduated from Manipal Medical College and subsequently finished her internal medicine training, her master's from USM Kubang Korea in 2015. Subsequently, she joined the fellowship program and was posted to various different hospitals, including Sarawak Hospital and Sedang General Hospital. Then she came down to Penang as well and as well as a stint in IPR. So she's very, very experienced. So I'm very, very happy and proud to introduce my colleague, Dr. Sangeeta, who's currently working as a respiratory and general physician in Pantai Hospital. I'm happy to have her on today to present this very important talk on vaccines for chronic respiratory illnesses. Thank you so much, Dr. Sangeeta. I leave the floor to you.
Good afternoon, everyone. Thank you, Dr. Uma, for the kind introduction. I told you to keep it simple. It's a really honor to share a platform with Dr. Uma. She was not only my ex-boss, but also a very good friend and mentor of mine, kind of thing, a really inspirational person. Okay, so without much ado, let me start my topic for today. It's vaccines for chronic respiratory illness, which I think is very, very important because it's not really the awareness for vaccines has it's just like a tip of the iceberg. The awareness is not there yet, kind of thing. So briefly, these are the contents of my talk today. Why are respiratory infections common in human? What are our body's natural defense mechanism? How do vaccines actually help, especially those with chronic respiratory illnesses? And what are the recommended type of vaccines, mainly for adults, and vaccination schedules, right? Okay, so why have you ever wondered why our respiratory tract is most susceptible to respiratory infections? Because mainly our respiratory tract, as we all know, is in constant contact with the ambient air for gas exchange. Okay, and to be effective, our respiratory mucosa is thin and it's constantly moist. Okay, so as a result of this, our respiratory tract is highly susceptible to the invasion of various microorganisms. So any disruption in this delicate structure will result in serious consequences and invasions of all these microorganisms. So, what microorganisms are we talking about for our respiratory tract infections? Mainly bacterial infections, which is 50% of exacerbations, up to 60% is caused by Streptococcus pneumonia, H. influenza, or Mozzarella catarrhalis. So, the presence of any upper respiratory tract infection usually leads to a more severe exacerbation of our pre-existing respiratory illnesses. And of course, the individual will take a longer time to recover from the symptom when they have exacerbation, and this would inadvertently translate to a longer hospitalization and frequent hospitalizations in our respiratory patients. Okay. So looking at the modes of transmission for all these infection agents, there are multiple modes, but commonly for respiratory tract is inhalational mode, which consists of both droplet and also aerosol. Okay, so when we say about droplet, we can imagine that it's a larger size particle, okay, more than 5 micrometers, and usually when it's larger size, the traveling distance or the distance whereby this nuclei or droplet travels is much less, which is about 1 meter. That accounts for the social distancing, the number when we say always social distancing 1 meter. So where did we get the 1 meter from? Okay, this is because of the particle size of droplet transmission. Okay, and the other one would be aerosol. Aerosol transmissions are more, they are finer particles. They are usually less than 5 micrometers, and because they are finer, they are lighter, so they can potentially travel a longer distance. Okay. So going into the second mode of transmission for all these infectious agents to invade into our respiratory system would be direct or indirect physical contact. Direct contact meaning directly with the infected individual who are constantly shedding viruses or bacteria in the respiratory tract or their excretes, like their fecal discharge. And these individuals are also contaminating surfaces and causing aerosolization. Okay, so and that is direct. So indirect physical contact would be when these infected individuals are spreading, or they are coughing, they have a poor cough etiquette, they are coughing out their viruses or bacteria onto surfaces. So the non-infected individuals are in contact with this contaminated formites. So we have indirect physical contact and subsequently transmission of these infectious agents. Okay, so there are many other defense mechanism against respiratory tract infections. Okay, mainly would be sneezing and coughing. So sneezing and coughing is not always bad. So that's why I always tell my patients that sneezing and coughing is actually not all pathological. In fact, it's one of the main defense mechanism against our respiratory tract infection, because how it helps is, as we all know, it causes a forceful expulsion of air to clear our mucus, and sneezing causes a violent contraction of our diaphragm, and it causes a powerful blast of air, whereby it pushes off all these potential invasion of microorganisms into our respiratory tract. Okay. The second main important mechanism would be mucociliary clearance. Okay. As we all know, our respiratory tract is lined by a layer of mucus, which acts as a physical barrier. This helps in trapping particles and pathogens, while the cilia in this mucus layer, okay, it helps move both the mucus layer and the fluid in the underlying periciliary layer. If you can see this cartoon here, the top part is the mucus layer, the second layer would be the periciliary layer and the ciliated layer, whereby there are lots of cilia, okay, so which moves these layers, okay. So what happens is when these trapped particles or pathogens which are trapped in this layer, they are swept from the distal airways, okay, to the larynx and towards the mouth, where they can be coughed and sneezed out, right? Okay, so the next defense mechanism, which is very, very important, is obviously our immune system, right? So our immune system is nothing but a complex network of cells, tissues, organs, which helps defend our body against invasion of all these microorganisms, okay? Our immune system can be divided into innate and adaptive immune system, right? So innate human system is it's our first line defense against all these pathogens, right? Okay, it acts almost immediately, and it's non-specific. Okay, that means it does not have a specific function. It protects against every pathogen, right? And how it acts is it has multiple barriers. Okay, either through physical barriers, which is through skin, through your mucus layer, or through even tears and saliva. Okay, right? So and the next part which is important in our innate system is also the cellular defenses. Okay, the cellular defenses comprises of phagocytes, which are our macrophages and neutrophils mainly. So this engulf potential pathogens or microorganisms from entering our cells, our body through phagocytosis. Okay. The second important defense mechanism would be adaptive or specific immunity. These take a longer time to kick in. Okay. This comprises of our humoral antibodies and also our cell-mediated immunities. Okay. So again, some revision of our physiology. Okay, I have to go through this. So adaptive immunity involves, as I said just now, specialized immune cells and mainly antibodies that attack and destroy our invaders, which are our pathogens and microorganisms. Okay, so and they are able to prevent diseases in future by remembering what those substances look like by mounting a new immune system. Okay, when our immune system is exposed to a particular pathogen or a particular antibody, they develop memory cells, okay, and they are able to remember, and they mount an immune response so that when there's a second infection, then they are able to wall off this infection. So the main key players in this immune system is our B and T cells. Okay, so having this in as a background, so what are the rationale and characteristics of vaccination? Okay, so and why is vaccination needed for us? So vaccine is basically a biological product. Okay, it can be used safely to induce the immune system. Okay, that confers protection against infection and or disease on any exposure of pathogen. Okay, so this vaccine must contain antigens that are either derived from the pathogen or they are produced syntactically to represent components of this pathogen. Okay, so this essential component of most vaccine is one or more protein antigens that induce immune responses, and this inadvertently provides protection to our body. Okay, so what are the characteristics of vaccination? Okay, so it protects against, as I said, it are protein. Okay, it protects against organisms that carry high mortality and morbidity. Okay, it prevents the transmission of these organisms in the community, and in order to achieve maximal impact, so these organisms should be those that cause widespread infection. Okay, and besides, these vaccines which are developed to be administered to us should be efficacious and it should be safe. So vaccines, obviously, they consist of weakened or dead microorganisms or part of microorganisms, which we call antigens. So when our body is exposed to these vaccines, it will stimulate our immune system to develop either humoral and or cellular immunity. Okay, so this process will always take a few weeks to complete. Like what I said, unlike the innate immunity, our humoral or adaptive immunity, it's not immediate. It takes a few weeks to develop the antibodies to be able to wall off the infection. Okay, so in severely immunocompromised individuals, this process may not take place, or they might take place with weaker responses. The individual might not mount the kind of response or antibody response which we expect them to. Okay, so that's where vaccination comes in. So what are the advantages of vaccination? Okay, so patients, namely with those with chronic lung diseases, so they tend to experience very rapid deterioration in their lung function because they have pre-existing chronic lung diseases and they already have a very limited lung reserve. Okay, so and in unvaccinated individuals, subsequent damage always occurs before the natural immunity kicks in, right? So because as I mentioned earlier, natural immunity will take some time to kick in, and before these individuals, because these individuals, some of them are immunocompromised because of their multiple comorbids, and sometimes they are so frail. So and on top of that, if they are unvaccinated, substantial damage always occurs before our natural immunity kicks in. So this is why vaccine is very important to these individuals, right? So what happens when they are immunized? Okay, their body's immune system are quickly activated. Okay, so and it's able to wall off the infection before damage occurs, okay, to their respiratory tract, or causes them to lose more of their lung reserve. Okay, so again, those with insufficient immune responses post vaccination may not be well protected. Okay, so for some. So vaccines in chronic respiratory illnesses, usually the response and the efficacy usually varies, depends on the vaccine and the specific illnesses. Okay, so vaccines mainly reduces the risk of infection, and it reduces the rate of hospitalization and death among our patients with chronic respiratory illnesses. So as you can see here in this chart, I'm not sure whether it's visible or not. Okay, so if you can see here, okay, the graph A, where looking at the incidences of pertussis way back in 1914, before the introduction of vaccine in 1940. So the incidence of diphtheria was very, very high. Okay, so and upon the introduction of vaccination in 1940, as you can see, the infection rate has declined to almost zero. Yeah, so that's how vaccine confers immunity. Okay, it prevents serious infections and almost eliminates these infections from our community level, right? Okay, so and influenza vaccination, which I think most of us are familiar with. So it's about 60 to 70% effective at preventing influenza among adults, right? So you can see the graph D, okay, that shows influenza type B infection, right? So before the introduction of vaccine in 1992, the infection rate was very, very high. Okay, and upon the introduction of vaccination, whereby people started becoming more aware of vaccines and their importance, okay, and they started taking them, okay, and even us, healthcare personnel, we started, identifying more patients who were suitable candidates for vaccines and administrating them. So you can see the rate significantly declining after the administration of vaccines, right? So this shows the efficacy also of vaccines before and after administration. Okay, so again, the next question in our mind would be, who should be vaccinated besides those with chronic respiratory illnesses? Okay, who else should be vaccinated? Okay, so I would say that pregnant women at any stage of pregnancy, okay, they should be vaccinated. Okay, of course, children, okay, age 6 to 5 years, we've got our national vaccination program. Okay, elderly individuals age more than 65 years old, because anyone who is aging, or those who are elderly, which is defined as more than 65 years old, as we age, our immune system tends to have a decline. Okay, our immune responses and immune system has a decline. So, and we are more susceptible to diseases and invasion of microorganisms. Okay, so it's recommended that elderly individuals should be vaccinated. And again, individuals with any chronic medical conditions, okay, or those who are immunocompromised mainly, okay, those who are receiving high dose steroids, those who have chronic illnesses, terminal illnesses like malignancy, post-transplant patients, right? Okay, so all these individuals should be stand a high risk of being susceptible to invasive infection, so they should be vaccinated. Okay, and of course, not forgetting us, which are healthcare workers, right? Okay, so just a bit about influenza virus. Okay, so what is influenza? Okay, influenza is a highly contagious, frequent, and serious disease. It's very, very common here. Okay, we have many subtypes of influenza virus. Okay, and currently we are also, having an influenza outbreak. Okay, so every year about 10% of the world's population catch influenza. Okay, this amounts to about 500 million people. Okay, so in severe cases of influenza, there are about 3 to 5 million affected severely every year. Okay, and this translates to about 0.29 to 0.65 million deaths per year. Okay, so this is about more than 3.5 million European hospitalization in Europe per year, right? Okay, so who are the risk groups who are prone for influenza infection as defined by WHO? So the very old and the very young. Okay, the old elderly is, like what I said, is more than 65 years old. Okay, and the very young is infants and children aged 6 months to 5 years, and pregnant women, okay, healthcare workers, and those with chronic illnesses. Okay, so an influenza virus belongs to the Orthomyxoviridae family. Okay, it's an encapsulated single-stranded RNA virus. Okay, so there are the core nucleoproteins used to distinguish the three types of influenza is A, B, and C. Okay, so for influenza A, the HA, or the heme agglutinin and neuroamidase, is used to differentiate the various subtypes. Okay, so the heme agglutinin, what it does is it binds to our respiratory epithelial cells and it causes cellular infection. Okay, and the neuroamidase, on the other hand, it cleaves the bonds that holds the newly replicated virions to the cell surface, and this again allows the continuous spread of the virus. Hence, that's why influenza viruses are very contagious. Right? Okay, this I mentioned. So okay, so why do we need a yearly influenza vaccination? Okay, why can't we just give one-off vaccination and then just forget about it, kind of thing, right? So why yearly is because, number one, our surface antigen changes, right? Every year surface antigen changes. Okay, and over the year our antibody wanes. Okay, so when it wanes, we need another vaccination. Okay, so however, there are no evidences that protection wanes during the influenza season, that the vaccine is received. Okay, and one dose is recommended per season, except for some children who are immunocompromised. Okay, so what are the adverse known adverse effects for this influenza vaccine? So actually, they are quite safe. It's a quite safe vaccine. Okay, for children and adults, they mainly cause mild URTI symptoms like rhinitis, sore throat, cough, chills, headache, and maybe pain at the site of injection will last about 1 or 2 days. Other than that, there are no known adverse adverse reactions to this vaccination. Okay, so but saying that, okay, we do have to take certain precautions, and there are certain contraindications to this to administrating these vaccines. Okay, so we have to take be cautious about those patients who are immunosuppressed from any cause. Okay, pregnant women. Okay, severe asthmatics, they might develop anaphylaxis towards this vaccine. Okay, and those with known severe anaphylactic reaction to egg or other vaccine components, because it's a protein base, it's mainly the base is egg. Okay, so those who have known anaphylaxis to egg, okay, we have to take special precautions when administrating these vaccines. Okay, a history of Guillain-Barré syndrome, okay, within the past 6 weeks following a previous dose should be taken extra caution. And those individuals suffering from moderate or severe acute illnesses, it's better to wait until they are in a recovery state before we are going to administer this vaccine. Okay, right. So when should we give these vaccines? Okay, in temperate countries like us, influenza peaks during the cold season. Okay, and typically influenza vaccination is given during autumn or beginning of winter in those countries with 4 seasons. Okay, so in tropical countries, okay, like in Malaysia, Indonesia, our neighboring countries, okay, there is no specific peak season. Okay, so we basically can administer influenza vaccine anytime, all throughout the year, right? So and usually what we do is we try to capitalize the opportunity for vaccination, especially when patients make a clinic visit or when they are hospitalized. That is provided that they are not suffering from acute to acute moderately severe infection. Okay, so we wait until maybe the infection has recovered just before they are discharged home, they are well. Okay, we try to vaccinate them. Okay, or when they are visiting us for a TCA or for an appointment, then we can optimize this opportunity or take this opportunity to vaccinate them. Okay, so those individuals traveling overseas or performing pilgrimage, especially in Mecca, so these people would benefit from receiving an influenza vaccine. Okay, just 2 weeks before their trip, or in other situations, okay, or during an influenza outbreak or influenza pandemic. Okay, it's wise to or recommended to vaccinate our population. Okay, this I mentioned earlier. One of the precautions we should take before administering this vaccine is to make sure that the person who's going to be vaccinated does not have a severe egg allergy. Okay, but this is not an absolute contraindication to vaccination. Okay. Okay, so a bit on vaccination for stable COPD patients. Okay, so our recent GINA guidelines recommended that influenza vaccination should be recommended for all patients with COPD. Okay, this is the evidence level B. Okay, and WHO and CDC recommends also COVID vaccination for people with COPD, even if the stable ones. Okay, and COPD patients are recommended to also receive 1 dose of pneumococcal vaccine, PCV20 or PCV13, followed by a PPSV or 23-valent pneumococcal polysaccharide vaccine 1 year after the first initial PCV vaccine, right? Pneumococcal conjugate vaccine. Okay, so what studies have showed is, a lot of studies have showed, why is this recommended is because a lot of studies have showed pneumococcal vaccination have been shown to reduce the incidence of community-acquired pneumonia, and which also prevents exacerbation in people with COPD. Okay, so the least number, the less the exacerbations COPD patient experiences, okay, the less the decline in his lung function. Okay, and also and vice versa is true. The more exacerbations they have, the quicker they are depleted of their lung reserve, and the more there is in decline in their lung function. Okay, so besides pneumococcal and influenza vaccination, CDC also recommends diphtheria and pertussis vaccination to protect against pertussis, which is whooping cough, for those patients, mainly COPD patients. who have not received their vaccinations during adolescence. Okay, right? So okay, I'll just skip this. Okay, so pneumococcal vaccination in elderly with chronic lung disease in the long run is actually cost saving. So I just wanted to highlight to you that this graph, okay, this was taken from a study by Nicole KL. Okay, this showed the health and economic benefits associated with pneumococcal vaccination way back in 1999. Okay, so as you can see here, over the 2-year outcome period, pneumococcal vaccination is associated with about 43% reduction in number of hospitalizations for pneumonia, okay, which has got a significant p-value, and this translates to also a reduction in risk of death as high as 29%. Okay, so this again, because of the reduction in the number of hospitalization and death, okay, this cost a cumulative 2-year net cost saving of US 294 ringgit per vaccine, per person vaccinated. Okay, so and in every scenario subsequently, vaccination was found to be cost saving strategy. Okay, so when we vaccinate patients, okay, it has been shown significantly to reduce the number of hospitalization and mortality. So and obviously cost saving, which translate to a better health economic status, right? Okay, so this graph shows, okay, our a percentage of confirmed cases of of invasive pneumococcal diseases per age group in Europe. Okay, as you can see here, what is very obvious is as our age declines, okay, elderly defined more than 65 years old, okay, the percentage of invasive pneumococcal disease, okay, is on the rising trend. Okay, it's as high as 53.1%. Okay, so why this happens is because there's such a term called immunosenescence. Okay, immunosenescence is basically decline of immune function per age. Okay, with age. Okay, adults which are high risk for developing pneumococcal disease, especially when they are aging, okay, they are higher risk of developing pneumococcal disease as their age increases, okay, because of this immunosenescence. Okay, so and also increased age is also associated with a greater risk of hospitalization due to community acquired pneumonia. So this is another graph showing incidences of pneumococcal diseases which increases with age and certain chronic conditions. As you can see here in the first graph, okay, this is a study done by Sheikh KF, published in the Open Forum Infectious Journal magazine in 2014. Okay, so you can see patients who are susceptible for invasive pneumococcal disease, okay, mainly very common among patients with chronic lung disease or COPD. They are 7 times at risk of developing IPD, okay, followed by those with chronic heart diseases, okay, and also diabetes, okay. It's about 3 times the risk of developing compared to healthy adults, okay. So the second graph here shows the incident rate of non-bacteremic pneumococcal pneumonia. Okay, again, as you can see, this is data taken among patients in the United States from the year 2006 to 2010. Okay, so and if you can see here, again, COPD tops the list at almost 9 times the rate, okay, compared to healthy adults, followed by chronic heart diseases and diabetes. Okay, that is why our guidelines were developed to and recommendations were developed to for COPD patients to be vaccinated against pneumococcal and also influenza. Okay, there are also other certain conditions which have cumulative effect in the risk of pneumococcal diseases, and this carries a very high risk of mortality. Okay, so pneumococcal diseases and especially the invasive one, the risk is higher and it increases with a number of medical conditions as shown in this graph. Okay, so mainly, as you can see, the one which tops the list is those patients with diabetes, chronic heart disease, and COPD. Okay, so patients with 3 or more underlying medical conditions have a higher rate of developing this disease compared to those with 1 or 2 chronic conditions. Okay. So looking at the seriousness of all this, okay, again, who are the recommended population to be vaccinated against pneumococcal vaccination, and what is the timing? Okay, so CDC recommends pneumococcal vaccination again for adults aged 65 years and older, again because of immunosenescence. Okay, any adults, younger adults 19 to 64 years old, if they have underlying medical illnesses or risk factors like, for example, alcoholism, chronic heart, liver, and lung diseases, okay, chronic liver failure, cigarette, those who are actively chronic cigarette smokers, okay, those who have congenital or acquired asthenia, those who have acquired or congenital immunodeficiencies, diabetes, anyone who is immunocompromised, those are who have underlying malignancy or receiving high dose of steroids, okay, or having any chronic conditions causing immunosuppression. Okay, all these people or population are recommended for pneumococcal vaccination. Okay, and what happens for those people who have never received a pneumococcal vaccination or those with unknown vaccination history? Okay, so if someone comes to you, they are not sure whether they have received a pneumococcal vaccination or what vaccination, or they've never been vaccinated, what is advised is or recommended is to administer a first dose of polysaccharide or pneumococcal conjugate vaccine, PCV 13. Okay, so PCV 13 or 20, if it's used, the pneumococcal vaccination is complete. Okay, so if PCV 15 is used, then it's recommended to follow with 1 dose of PPSV. PPSV is pneumococcal polysaccharide vaccination. 23 is basically the number of strains which the pneumococcal vaccination covers. Okay, so the recommended interval between these 2 vaccinations is at least 1 year between from the last dose of the PCV vaccine received. Okay, and the minimal interval is 8 weeks and be considered with in adults with immunocompromised condition, whether it's a cochlear implant or those who are having a cerebrospinal fluid leak. Okay, so when PPSV 23 is vaccination in this population, so they are considered to have a complete pneumococcal vaccination. Okay, so yeah. So this I mentioned earlier. Right, I'll skip this. Okay. So okay. So let's go to our target population here. Okay. So elderly adults with chronic medical illnesses. Okay. So adults more than 65 years old without immunocompromised situation. Okay. So recommended they receive PCV 13 at any age. 1 year later, administer a PPSV 23. Okay. At 65 years or older. Okay. So if younger adults, 19 years or older, those with risk factors like a CSF leak or cochlear implant, okay, so what we recommend is to give a PCV 13 at any age, and 8 weeks later or 2 months later, administer a PPSV 23, or at before the age of 65 years old. Okay, and at least after the age of at least after 5 years apart, they should receive another PPSV 23 at if they are more than 65 years old. Okay. Okay. So this I've already mentioned earlier, kind of thing. So I think that's my last slide. So thank you very much. So is there any questions from the floor?
Okay, so maybe now I open the floor to questions. I think we have quite a number of participants today. You can either raise your hand for a question or you can put it in the Q&A box. I just tapped just now and there were no questions. Maybe if there are no questions, I'll be the first one to ask Dr. Sangeeta some questions, if Dr. Sangeeta don't mind.
Yeah, that's all.
Okay, so one of the things I always have difficulty is the first time you want to vaccinate a patient, because in my practice also, I'm sure it's in yours, the first time we see some patients is when they come in for pneumonia and they get admitted. And these patients may have some underlying lung disease. And memang, according to guidelines, they are entitled for vaccination. So to put it simply, what would you recommend? A patient who either has chronic lung disease or is more than 65 years old without any chronic lung disease, which is the first vaccine do you administer?
So the patient who is non-immunocompromised, so we could, and they are more than 65 years old, we could give a PCV 13 first for the patient kind of thing. So and later on, the second vaccination, 5 years later, 1 year later, we could give them a PPSV 23.
Okay. So let's say, like previously, many of our patients already have received their PPSV 23 because, as you know, in government, that's quite easily available.
Yeah.
So would you recommend a PCV 13 1 year later or no?
Because PPSV 23 already confers immunity for almost 23 strains of the pneumococcal strains kind of thing on that. So I wouldn't. I think the next vaccination would be another 5 years later for another PPSV 23 kind of thing.
Right. Thank you very much for that, because I think there's some confusion there, because I get this asked a lot, what vaccine to give, and also, and many of patients unfortunately already have PPSV 23, fortunately maybe, but so patients come and ask you whether they should take the Prevnar as well, because they also read and they also want to know that. Okay, another thing, maybe Dr. Sangeeta may be able to answer, because she's mainly in the private practice as well. In the government, we only have PPSV 23 and Prevnar 13. Do you have PCV 15 or in your hospital? Maybe we can send our patients to you.
We have a PCV 20 in our hospital.
Oh, really?
Yeah, we have PCV 20 and also PCV 13. Okay, besides PPSV 23. So usually we administer a conjugate vaccine first, because it confers a broader immunity and a more holistic coverage to our patients before giving them a PPSV, a polysaccharide vaccine, 1 year later. Okay, because polysaccharide vaccines usually they are sugar-coated vaccines kind of thing. So and what happens is these conjugate vaccines actually they trigger a more robust immune response because they involve both the T cell and the B cells. So that's how they confer a longer term protection and memory cell development. So and compared to PPSV, whereby it contains just like as the name itself is a polysaccharide vaccine, so it's a sugar coated vaccine of the 23 pneumococcal strains. So the protection is shorter but the coverage is also quite broad against 23 strains of pneumococcal viruses, pneumococcal organism.
Okay, so let me see. Are there any questions so far? So maybe my last question before I tire out for Dr. Sangeeta. Do you have any idea how much it costs, the PCV 20 in the private practice? Again, because maybe I should just refer patients to you. So that's a superior vaccine in terms of coverage compared to anything else we have.
It's not so expensive. I think it's about 180 ringgit for a vaccination. The influenza vaccinations are cheaper at 90 ringgit. The pneumococcal is about 180 ringgit.
Mm. Yeah, thank you very much for your talk today. I think I personally have learned a lot as a good refresher for me. And I'm sure the participants have also, garnered much knowledge after your experience, after your good talk. And I think we'll be more confident to promote vaccination more robustly to our patients. I think I totally agree with Dr. Sangeeta. I think once we have elderly patients admitted for pneumonia, the outcomes are sometimes undetermined. Sometimes, patients come very ill in the government and in private as well. You're talking about costs. So, okay, there's a question from the floor. What about the attendance for today? Is that how are they capturing attendance or for the certificate? Maybe Dr. Liu can answer, or maybe the College of Physicians.
I think I will ask Afiq. I will get back to the participant. I think, but the attendance usually will be recorded.
Yeah, correct. Automatic recorded.
So that means they don't have to, including me, we don't have to scan a QR code or anything like that, lah.
No need.
No need, okay.
Yeah.
Glad to hear, lah. I'm okay. Okay, thank you very much for that. I think the take-home message for patients is, I think try to consider why you should not vaccinate patients. Looking at the long list of indications that patients need vaccination. I think that's the first question. If you have a patient in front of you, see whether the patient requires vaccination. I think it does save lives. Dr. Sangeeta has clearly, beautifully presented some data on that as well. So I think on my part, I think we are finished for the day. Unless Dr. Liu or College of Physicians or Dr. Sangeeta, is there anything else you want to add? Maybe Dr. Sangeeta can close up with a final statement.
So yeah, so I think as just physicians, vaccinations definitely reduce hospitalization, okay, and hospitalization again reduces mortality. So we should actively identify patients or populations to be vaccinated, because I don't see many patients having the awareness of vaccination. Only those who are going for pilgrimage, then only they start actively looking for us for vaccination. Other than that, they are not aware that they should actually receive vaccination on a regular basis on the recommended schedule: yearly influenza and 5 yearly pneumococcal. Okay, so we don't have the awareness yet. They don't have this vaccination card. So maybe we could, just like how our children, right? So they have a vaccination schedule. Maybe for our elderly patients, we should have a vaccination schedule of what they have a vaccination card to actually have a data on how much they, whether they are adequately vaccinated or not, kind of thing. So
thank you. Yeah, that's well said, Dr. Sangeeta. I think on my part, I think we will close the talk for today. I'd like to thank the College of Physicians for kindly allowing us to present this very important topic, and also for the kind invitation to both myself and also Dr. Sangeeta to be here this afternoon. I hope the participants managed to, get some additional knowledge after this talk. And with this, I would like to thank everyone.
Thank you, Dr. Sangeeta and
Thank-
Dr. for sharing
thank you,
this
Dr.
session.
And Dr. Liu, and also the chairman, the organizers, which are the College of Physicians, for the invitation. Thank you very much.
Okay, I think this will
Thank you,
be the
Doctor.
end of the webinar today. We'll see next month. We'll begin with a new role, starting with week 1. Okay, thank you, everyone.
Okay, thank
Thank
you.
you.
Thank
Bye.
you.
Bye. Have a nice day.
Mm.